So what we'd say is we have about 500 cases per 100,000 individuals. That's quite high. And then we look at something called incidence, which is the number of new cases in a year. And in Kenya, we get about 120,000 new cases annually.
You may still find, even a year or two after somebody has been treated and they had the granulomas, you may still find those, if you did an X-ray of somebody's chest 2 years after they were treated, you may still find features of that in the lungs.
In the dusty streets of Kenya's cities, the quiet corners of rural clinics, and even within the bustling life, an old enemy continues to stalk silently: tuberculosis. Once thought to be a disease of the past, TB remains one of the top infections in Kenya and around the world. Every year, tens of thousands of Kenyans are diagnosed with this airborne illness, some early, others too late. But behind the numbers are real lives, men, women, and children fighting a battle that often goes unseen. From the stigma surrounding the disease to the long road of treatment and the tireless efforts of healthcare workers and community health volunteers, the TB story in Kenya is layered, urgent, and deeply human. In this episode, we focus on the state of tuberculosis in Kenya, what it is, why is it still with us, and how doctors and communities are rising to confront it.
My name is Dr. Shamsa Ahmed. I am a consultant physician and I am the head of the Infectious Diseases Clinic and the Travel Medicine Center at the MP Shah Hospital. So tuberculosis is an infection that is caused by a specific bacteria called Mycobacterium tuberculosis. Essentially, it is an infection of everything. We usually say it can affect everything apart from your hair and nails. The one that we are most commonly aware of in Kenya is when you get a pneumonia or a chest infection from tuberculosis.
Now, how is tuberculosis spread?
My name is Dr. Anju Guna. I'm a family medicine and staff clinic doctor at MP Shah Hospital. So tuberculosis is spread through air, so somebody droplets in the air. That is the primary way that it is spread. Yeah.
Most of the times TB is transmitted through aerosol droplet. So let's assume that I have an active TB infection within my lungs. As I am coughing and sneezing and talking, every time I do that, I'm actually spreading that bacteria in the air. So if I'm next to someone who doesn't have an infection, three things can happen. As we have the interaction, they also end up taking in that bacteria into their system. The first thing that can happen is their immunity will kick into gear, fight it off, and nothing happens at all. The second thing is your immunity fights it off, but what happens is it ends up walling it or hiding it somewhere else in the body, maybe in a cavity or in a lymph node, and maybe much, much later in your life when your immunity is interfered with or drops, you find that TB wakes up or becomes reactivated. Alternatively, you can just get a full-on TB lung infection exactly as I had.
TB is still common in Kenya with over 90,000 cases reported in 2022. While deaths and new cases have dropped since 2015, many people, especially young adults and the elderly, go undiagnosed or untreated.
So unfortunately, Kenya is one of the countries in the world that has one of the highest TB burdens. So what we'd say is we have about 500 cases per 100,000 individuals. That's quite high. And then we look at something called incidence, which is the number of new cases in a year. And in Kenya, we get about 120,000 new cases annually. And usually you find a big burden is actually within children. So about 10% of these people we're talking about who are infected are actually children under the age of 12.
There are various risk factors associated with tuberculosis, which makes one more susceptible to acquiring the disease.
The risk factors for TB are similar to all infections. So extremes of age, if you're very young or very old, because if you're very young, then you don't have an immune system to fight things off. If you're very old or elderly above age 60, it means that your immune system has been used quite a bit. So now it's a little bit exhausted. If you have anything else that can lower your immunity, so other diseases such as HIV, if you're a dialysis patient, if you're a cancer patient, if you're on any kind of immunosuppressive therapy. One thing I'll say, it doesn't mean that everybody who has TB has HIV. there's a good population of young, healthy individuals, especially young males who are in that 18 to 35 age group who tend to be susceptible to getting TB. And that's a lot because of the lifestyle they're living. So that is sometimes is overcrowding. So if you're in a boarding school, if let's say you're in the army, any kind of thing that puts you in close contact with poor ventilation, malnutrition. So again, if you're not eating well, then obviously your immunity will be lowered. If you have any kind of structural lung disease, like things like COPD, ILD, then you tend to be more susceptible. Then of course people may be in war-torn countries, refugees, but again that tends to be circumstance. You have a large group of people who have low immunity and they're all kind of herded into one area.
Any place where you're in close proximity, so even socioeconomic status has an effect. So essentially slum areas where people are very condensed tends to be one of the risk factors. And of course, contact with somebody who is actively being treated for TB is a risk factor for you to also develop it, yeah.
With TB, the infection usually progresses slowly and symptoms may develop gradually over a period of weeks or months.
One thing, we say TB can present with everything and nothing, but the things that we look for, one is a cough that has gone on for more than 2 weeks, so that's a chronic cough, yeah. It is productive, meaning you're bringing up some kind of sputum, and most of the times it is blood stained or blood tinged. You will have weight loss, and that is unintentional weight loss. So it's not that you're on a diet or you're exercising and you're losing weight. They tend to have fever, and especially night sweats. You can have very drenching night sweats. So those tend to be like your cardinal symptoms when you're referring to TB. But remember, you can have none of these symptoms and still have TB, or can have a few of these symptoms and have TB. And that will usually link you to having TB of the chest.
You can be given antibiotics, 2 or 3 rounds of antibiotics, and it's not responding. Extrapulmonary TB, that is TB that essentially has gone to any part of the body. So generally you would have the same thing, so low-grade fever, fatigue, loss of weight, and then lymph nodes, inflamed lymph nodes on different parts of the body, and then symptoms related to which organ or where the TB has localized itself.
TB causes granulomas as a defensive response by the immune system trying to control the spread of the infection. A granuloma is a structured collection of immune cells that form around the site of infection, essentially as the body's way of wailing off the TB bacteria to prevent it from spreading.
You may still find, even a year or two after somebody has been treated and they had the granulomas, you may still find those, if you did an X-ray of somebody's chest 2 years after they were treated, you may still find features of that in the lungs.
Sometimes your immunity will fight it off and it'll just sit there quietly. Sometimes it'll wait until it'll wake up. And when it wakes up, definitely you'll start to get some kind of symptoms. So whether you'll get like swelling of your lymph nodes, whether you start to lose weight, you're having fevers, you feel very lethargic. So at some point, it'll start to show you symptoms that it's actually there.
Diagnosing TB involves a combination of clinical evaluation, laboratory tests, and imaging techniques.
So usually you need to get some kind of a tissue sample. So it depends on the site. Most of the times, if it is lung TB or pneumonia, then we need to get a sputum sample, an early morning sputum sample, not the middle of the day, otherwise you'll be giving saliva, because what you're trying to get is something from deep in the chest. If the patient is not able to give a sputum sample, these days we have something called a bronchoscopy, where they actually put a small camera down into the lungs and they wash up the lungs and they can take a sample from that. If you have, say, TB that we think is possibly in the brain, there's a way we take some spinal fluid for assessment. If there is swelling of a gland, we try and take tissue from that gland. So the point is we need to get a sample of where we suspect the TB to be from. That's usually a direct test. We have some indirect tests that can be done sometimes on urine, sometimes on blood, to help us look for maybe the breakdown products of tuberculosis, but those are for a very specific population. It tends to be people who have very low immunity that we can do the other tests for it.
We would also do a chest X-ray or a CT scan, particularly of the chest, if the symptoms seem mainly to be in the chest. And of course, if they're somewhere else, we would do a CT scan or MRI of the other part of the body. For instance, if you have TB of the spine, we would need to check your spine, do an MRI of the spine to look for signs of the tuberculosis.
Antibiotic resistance in Kenya is a growing public health concern, driven by the overuse and misuse of antibiotics in both healthcare and agricultural settings. Antibiotics are often prescribed unnecessarily or taken without proper guidance, leading to the development of resistant bacteria. So what is antibiotic resistance?
So if you have any infection, let's look at the infection like an invading army. They have like 100 soldiers in the body. So when you want to set up your defense, you know that you're going to need a certain number of your own soldiers, and they need to be showing up at certain times to cover the shifts to make sure that in the end they're going to get rid of these 100 soldiers, this invading army. Now, if you're supposed to set up 500 and they're supposed to come 3 times a day, that's how you're going to kill off these 100 invading soldiers. But if for day one you give the whole army shows up on time, maybe you've killed off, but there's about 50 soldiers still waiting. If you keep giving gaps, what you're doing is you're allowing this invading army enough time to go and get other recruits to join them. You're giving them time to find different ways to get through your defenses, which is why by the time you don't finish those antibiotics, you might think you've dealt with this issue, but that invading army, all they've done is gone and sat somewhere, and they're just biding their time for when they're going to show up and come back much stronger, much tougher to defeat, because now they've understood your defenses. So you look at it like that, like the antibiotics are your army, so you need to have the right number of people at the right time doing the work that they're supposed to do.
Coming up after the break.
Another thing I'd recommend against is getting a stat, or rather an initial IV injection or an IV drip as the first dose, and then going away with tablets.
And the other thing would be, of course, testing and adequate treatment for HIV, because that would come coinciding with TB. And then,
as we've seen, TB remains a serious public health challenge in Kenya, with rising concerns around antibiotic resistance, making the fight even more complex. From the symptoms that creep in slowly to the complications that arise when treatment is delayed or interrupted, TB demands urgent attention and sustained efforts from all of us. When we come back after the break, we will have a one-on-one chat with Dr. Shamsa and also take a closer look at how Kenya is tackling TB through diagnosis, treatment, and community-based interventions. Stay with us. And now for a short healthcare tip. One of the most effective ways to prevent TB is by strengthening your immune system and reducing exposure to the bacteria. That means living in well-ventilated spaces, especially if you're in close contact with others, as TB bacteria spread through the air when someone with active TB coughs or sneezes. If you work or live in a high-risk environment, like healthcare settings or crowded living conditions, wearing a mask and getting regular screenings is crucial. And if someone in your household is diagnosed with TB, make sure they follow their treatment to protect themselves fully and others. Remember, TB is preventable and treatable, but early action makes all the difference.
We are living in a lost and broken world, constantly bombarded by messages of hate and atrocities. But with God, we can overcome. Find hope and restoration on the go through life-changing shows on the Family Media app.
And then you will lose yourself and gain the world. And Jesus said, what good is it?
Get to stream Family TV and Family Radio 316 straight from your phone. Catch up on a show you missed or create video streaming playlists by saving and watching videos from our huge variety of shows at your own convenience. Download the Family Media app, available for all Android and iOS users on the Google Play Store and Apple Store respectively. Family Media, keeping Jesus on the airwaves.
Welcome back. Before the break, we explored what TB is, the symptoms to watch out for, and why antibiotic resistance is raising the stakes in the fight against this disease. Now, we turn our focus to the front line. How is TB diagnosed, and what does treatment look like? Let us speak to Dr. Shamsa one-on-one as we go deeper into the topic.
So earlier we spoke about drug resistance.
Yeah.
Now I know what happens sometimes when people are older and they go to hospital, they tend to succumb to some infections because of drug resistance, because they've been taking antibiotics most of their life. Tell me about that, and what can people do to prevent that in the future?
So that is a little more complicated when you're picking up a drug-resistant infection in a hospital. One is, yes, if in your lifetime you have been misusing or having antibiotics misprescribed to you. So you've been taking the wrong antibiotic, maybe in the wrong dose, or taking it too frequently. It means that one, the bacteria that you might be carrying has already developed a smart way around other antibiotics. And then if you're older, you might have been having recurrent infections, and because you've had to use certain antibiotics, maybe it was even the correct antibiotic at that time. Remember that bacteria are smart. Their main aim in life is to exist and to make sure that they reinfect someone. So what they're trying to do is come up with mechanisms to avoid whatever you're using to treat them. In a hospital scenario and with an elderly person, you tend to find what is here is the toughest bacteria because it has been exposed to some of the strongest antibiotics. And that's why we say it's like multi-drug resistant. So you'll find one bacteria cannot be treated by maybe 10 antibiotics. So you're left with maybe only a single antibiotic that might be very expensive or very difficult to get. Or sometimes we go in the opposite direction and go back to a very old school antibiotic that maybe has not been used before. So they're the things in terms of personal health, which means even if whether you're elderly or whether you're still young, trying to keep as healthy as you can, trying to eat well, try to get rid of bad habits like smoking, trying to stay in well-ventilated area, and of course trying to get vaccines for whatever has a vaccine. And then an antibiotic should only be prescribed by a doctor, not over the counter. It should be the right antibiotic for the right thing, meaning if it's an antibiotic that's used for an upper respiratory tract infection, we don't want to use it for, say, a urinary tract infection, because those are different bacteria working in different areas. We don't want to use antibiotics if it's a virus and it's a short-lived infection. And whatever you've been given, complete the dose. But that also means we shouldn't treat things for too long. So these days, even in antibiotic terms, we say shorter is better. So if something can be treated for 5 days, when we take the antibiotics and we stop. Not that we continue with the antibiotics for 2 weeks, because then we feel we're really doing a good job. So right dose, right disease, and right duration.
People who tend to go to pharmacies a lot, which a lot of people tend to be honest, before they go to the doctor, just get given antibiotics, sometimes which don't even align to anything they have. How can they protect themselves?
I mean, one is education. If you, like you said, you're literally taking yourself to that person. That person didn't come looking for you. Understandably, it's easier. You're not paying a consultation fee. There's no queue. You're being seen within 5-10 minutes. You feel like you're being seen by a medical professional. Also, you need to realize that not everybody sitting at the pharmacy is a pharmacist. You can easily just have someone who's maybe managing the shop for that day, giving out the antibiotics. You also have to understand that there's a monetary value for the person selling you that medication. So sometimes if you want the quick and easy way now, but that leads to a long-term morbidity or issue later. So sometimes it may be harder, it may be tougher, but the better route is to actually see a proper doctor, get a good evaluation, and understand whether you need an antibiotic and which antibiotic you need to take. Another thing I'd recommend against is getting a start, or rather an initial IV injection or an IV drip as the first dose, and then going away with tablets. We need to be very clear. Do you need an IV antibiotic or do you need a tablet antibiotic? Do you need to be in hospital or not? Some of these shortcuts is what is causing our problem, taking a high dose quick injection and then transitioning to a tablet. Sometimes those two don't even align, meaning what they've given you as an injection and what they move you to as a tablet are not even in the same spectrum. So we need to be very clear. Do you need an antibiotic? Fine. Does it need to be IV or does it need to be oral? And how many days do you need to take it for? And what is the appropriate follow-up?
So for instance, we know the common cold virus, it stays in somebody's body pretty much their whole life.
Yeah.
But with TB, you said it's a bacteria.
Yeah.
Does that mean that it can actually leave somebody's system completely?
It's curable. One is we have all lived in Kenya. We've all been exposed to TB. There's nobody who has not been exposed. Whether you live in the richest part of the country or the poorest part of the country, we've all been exposed. Majority of us, our immunity has fought it off. We've never even noticed it. There's a percentage where it is hidden, and maybe even if I did tests and all, I might not be able to find it till the day it actually shows up. For the people who have the symptoms and we can diagnose it. As long as we're catching it in time and you take the medication as prescribed, TB can be cured. We can remember there was an old Kenyan health campaign. It was TB inatiba. It means it can be cured completely.
The treatment of TB is both effective and widely available, but it requires patience, discipline, and consistency.
The beauty of TB is this treatment. It's treatment and you can be cured. So again, depending on the site, there is a combination of antibiotics that we use, very strong antibiotics. If it is in the lungs, we usually treat it for about 6 months. If it's in a different site, maybe the brain, maybe a lymph node, sometimes we can extend that treatment to 9 months or 12 months. But there's a very good cocktail of antibiotics that you can take that can treat it. Usually first a test is done to try and see is the kind of TB you have what we call sensitive or resistant. If it is sensitive, there's a beautiful cocktail of drugs. If it is resistant, we still have what we call second or third line medication, and sometimes you have to tailor it towards the specific patient. What is concerning us now in Kenya is what we call drug resistant TB. Because sometimes what you find is maybe it's a patient who has taken medication and defaulted or not completed or partially treated, or maybe has been exposed to these antibiotics in the wrong dosages, and now the kind of TB that they have is resistant. But even for that, now in country we have the kind of medication that can be given to them. It's only that kind of a patient is watched a little more closely to make sure that they complete the dose and duration of treatment.
For pulmonary TB, it's in the lungs, and it's the first time we would treat you for 6 months. It's a long-term treatment. So if it's multi-drug resistant TB, we would then extend the treatment to 9 to 12 months. Also change the drugs to what is sensitive based on the resistance pattern of that TB.
TB can be prevented, and while not all forms of prevention can offer absolute protection, a combination of public health strategies and individual actions can significantly reduce the risk of infection.
Avoiding overcrowding is one important thing. And the other thing would be, of course, testing and adequate treatment for HIV, because that would come coinciding with TB. And then for those of us who are at high risk, for instance, healthcare workers should be regularly screened and properly managed if they are exposed. It's generally a community-acquired infection, so all you can do is avoid close contact with people who are suspected also to have TB. That would be another way to prevent yourself from getting it.
Prevention is the number one thing. Preventive medicine is the way of the future. So number one is things like this: public service, public awareness, getting people to know what is the disease, when are you likely to contract it, where should you go if you're worried about getting it. For the younger population, the vaccine is important. If you've been born in East Africa, we all have a little scar here on our forearm. That is a BCG. It's a vaccine that we got as infants. That can only be given until age 16, but that gives you some prevention from getting TB of the lungs. So if there's a vaccine, we need to get it. And if you have kids and they haven't got the vaccine, make sure they get it. In terms of a preventive tablet, there's something in country called TB preventive therapy. These are antibiotics similar to what we use for treatment. They are given to either people who have low immunity, like maybe patients who have HIV, or family members who have been exposed to someone with TB but don't have the infection. It's simple medications you take once a week for 3 months. It also gives you protection for up to 2 years from getting TB. This is available in country and it's free. And then of course etiquette. So if you're coughing, cover your mouth, cough into your elbow. If you're not feeling well, there's no need to be the person attending big parties if you're the person who's coughing, having a flu, and obviously go and seek medical help or medical intervention.
Diet and lifestyle play a key role in preventing TB by strengthening the immune system.
Generally, just a healthy diet with fruits, vegetables, foods high in immune-boosting minerals and vitamins. That would boost your immunity and help you to be able to fight the tuberculosis.
Exercise. Yeah, we all need to do something. Walking around your compound slowly, gossiping about your neighbors doesn't qualify as exercise. You need to do something at least, to twice or thrice a week, half an hour. You need to feel like you're sweating. You need to feel like your heart is beating fast. It doesn't have to be fancy. We don't have to join gyms and do Zumba and all of those kind of things, but you need some kind of activity. Even playing with your kids, like actually playing with your children, qualifies as exercise. If you're smoking, you need to stop. There's nothing beneficial about smoking, whether it's shisha, vape, cigarettes, all of that.
The Kenyan government has implemented several initiatives to combat tuberculosis.
So with TB, we have really robust programs. We're one of the countries with one of the best programs. We've come a long way in terms of TB. At some point, there was even something that they had something called a TB manyata, meaning what they used to do was at smaller district hospitals, they actually had accommodation for people who had TB. So they would actually live near the hospital. That way they could still have their privacy, not being within a ward. They can cook, they can clean, they can stay in their house, but they were getting their medication daily and being observed taking their medication. Now there's actually an initiative that if you look at the packets of the anti-TBs, there's actually a code that comes when you take out the tablets. So you're supposed to type in that code and send it. If you don't, then you get a text to remind you that you need to take your medication. Anti-TBs are provided free in this country, depending on where you're getting it from. So that is already a big initiative. There's something that's been going on since 2021 that's even in terms of the diagnostics. So that means you can get a lot of tests also done for free, because some of the tests for TB are complicated.
So we have several very large TB initiatives. And for instance, across all public hospitals, treatment is free, it's fully subsidized and is free right now. So there's been a lot to do with TB, just as we have for HIV. TB is, as of now, is well funded, the drugs are available, the testing is available, all the equipment is fully funded and available for treatment of TB right now.
As we close this episode, we've seen just how deeply TB still affects lives across Kenya. From the silent symptoms that often go unnoticed to the resilience of survivors and the tireless efforts of healthcare workers. TB remains a battle we must all take part in. But there is hope, because with early diagnosis, consistent treatment, increased awareness, and strong community support, TB is treatable, preventable, and curable. Thank you for watching. Until next time, stay informed, stay healthy, and let us keep the conversation going.